It's my privilege and pleasure to introduce to you Tim Hassett-Sally, the Regional Director of the Workers' Compensation Research Institute. Tim journeyed all the way down here from Boston to talk to us today. We first met Tim down in Florida in June.
Go ahead.
We first met Tim down in Florida in June when we had the pleasure of hearing him speak on this very topic at the National Conference of Self-Insureds. And it was a tremendous presentation, and we all agreed that it was important for us to hear it again. So Tim is the Regional Director of the Workers' Compensation Research Institute. It's a nonprofit think tank, and I'll let Tim explain a little bit more about the work that they do. But before I do, I just want to let you know that next week, the Pennsylvania Bar Association PBA presentation will take place in Hershey, and our very own Regina Parker will be one of the speakers. I also wanted to let you know that next year, Katie Bavoso will come in as the statewide chairman of the chairperson of the entire state bar, workers' compensation practitioners. So we're all looking forward to her leadership. Without further ado, Tim Hassett-Sally.
Thank you, Bert. Thank you very much for your hospitality and for having me here today. Good morning, everybody. Happy Friday. I've been asked to talk about opioids, and recently I was cleaning out my basement. All three of my kids are now gone, so we can do that. And I came upon a box of old stuff. And I was looking through it, and I had done a presentation in 2004, right after the Red Sox won the World Series, by the way. And I was looking through that presentation, and it was on what we called opiates at the time. And when I looked through the presentation, I really could have used the same presentation today as I did back then in 2004, and changed opiates to opioids, and we would have had today's presentation. Obviously, I work for a research institute, so we've got updated information. But I just thought it was striking how little, in some respects, the world of opioids has changed in that period. So today, we are going to talk about opioids. Before we get to that, I do want to give you a little overview on the Pennsylvania Workers' Compensation Benefit Delivery System, and we'll take a few minutes even prior to that just to tell you who we are at WCRI in case you haven't heard who we are. I will say that the last bullet point on this agenda we might not get to just for time's sake, but I wanted to put that in the presentation. You have the slides. And it represents a very recent research report that we did, which is very unique in that it actually looks at causation rather than just correlation. And almost all research up to this point has been looking at correlation. So this is very exciting for us. Any people who are into statistics, if they can find something that has causation, it's something to get excited about. So let me tell you a little bit about WCRI, okay? We've been around for about 35 years. We're an independent, not-for-profit research organization, think tank, as Burke put it. We have diverse membership, employers, insurance carriers, state agencies, defense firms even, carriers, TPAs, service providers. So we have a large stakeholder interest in what we do, and all of these organizations together help support the research that we do. We focus on benefit delivery systems. We do not focus on rate setting. There's another organization in many states that does that, and you have a private rating bureau here in Pennsylvania that is concerned with that. And we are a resource for the public and for stakeholders in the workers' comp arena. There's our mission statement. I'll let you read it if you'd like, but the key word is catalyst. We're a catalyst. We don't make policy recommendations. We don't take positions. We don't give opinions. We're always asked to, but we don't. We are nonpartisan, but we just give the facts. So our studies are all peer-reviewed. We are very confident that they're accurate. They're all statistically based. But we're just providing facts. We leave it up to the stakeholder groups to decide what to do with our facts. The way I look at it is we give actionable intelligence, and it's up to the stakeholder groups to take action. We do have a very robust, finally, website. Our old website is in the website museum somewhere. We have a new website. We have over 600 studies on the website. We have some members here today. Thank you very much for being members of WCRI. You're entitled to go in and get the research for free. If you're not a member, the research is still available to you, but you'll have to pay. We give webinars all the time. If you get in touch with us, we'll put you on our email list, and we can make you aware of webinars. There was one yesterday, as a matter of fact. I don't know if anyone signed up for it, but it was on the new physician dispensing reforms in Pennsylvania. So it was apropos for what we're speaking about today, and I will go over those results. I will also say one more thing before I jump into the presentation, is that I've compiled these slides based on several different reports, and each report will run anywhere from 80 to 120 pages. So we're really setting ourselves up for an impossible task this morning to try to get through a lot of research. So some of it will seem like we're going through quickly. I'm glad that you have the slides in your booklets, but it's not meant today to go into the kind of detail that you can get if you actually read the reports, but I will give you an overview. So let's jump right into a little overview for Pennsylvania. And this is not opioid related, this is overall Pennsylvania performance. The total costs for claims in Pennsylvania were higher than in most other states. As you can see, Pennsylvania off there to the right. That's a total cost for claims with 36 months of maturity in a claim. We look at claims with 7 or more lost time cases. So throughout our research, we're going to be focusing on cases that have 7 or more lost time days, because that's the kind of the common denominator for states. We look at multi-state comparisons. Some states have a 3-day waiting period, some a 5-day, some are 7 days. So we use 7 days as our common denominator. The other reason is that the vast majority of all expenses on claims are paid for claims at 7 days or more lost time. So just what is causing what is responsible for the relative high amount of cost per claim? Pennsylvania had 2 large cost drivers for total cost per claim with more than 7 days of lost time when compared to the typical in study state: indemnity benefits and litigation expenses. So you can see here, most of our ratings are either going to be higher, lower, or typical. Some of our reports will say higher, lower, or similar. So you can see here that indemnity benefits and litigation expenses were higher. Benefit delivery expenses, which includes those litigation and medical cost containment, was considered higher. You look at medical payments per claim, it's showing typical, so around what the median state is. So what's really driving the higher cost in Pennsylvania is the high indemnity and high defense litigation costs. Sorry if I'm raining on your parade here. So this is just another graph showing what the actual breakdown is. The indemnity benefits were the largest cost component in Pennsylvania for claims with more than 7 days of lost time. Okay? When we look at, so I said this is a 36-month duration claims. If we look at 72 months, the figure really doesn't change that much, and the relative position of Pennsylvania on the national scale does not change. So they're higher at 36, higher at 72 months. Well, looking at that, why is the indemnity so high? Well, your average weekly temporary disability benefit rate is one of the highest, and as well as the longer duration of temporary disability. So between paying more per week and for a longer duration, that's where you get the high amount. Also, lump sum payments per claim are higher than average in Pennsylvania, and you have more of them. And we're not saying that's a good thing or a bad thing. It's just what it is, and it's just a feature of the system in Pennsylvania. So we've got this chart up here, and showing that there are different types of benefit systems throughout the country. And Pennsylvania has a wage loss benefit system. Not all states are like this. I kind of grew up in the Massachusetts system, thinking that all states were a wage loss benefit system, but as it turns out, we're in the minority. Your system continues to pay, as we just heard in the legal briefs, continues to pay benefits beyond the point of MMI if someone has not been able to return to work or hasn't been able to return to work and match their pre-injury wage. So that's similar to a few other states, and almost all of those states in the wage loss columns are going to be higher because of the features of the law. As I mentioned, you have a high weekly TTD benefit rate, the highest in the group. I'll also caution you when you're reading these, we study sometimes 18 states, sometimes 26 states, sometimes all 50 states. Most of the reports that we're looking at today involve 26 states or thereabouts. So we're not saying that Pennsylvania is the highest in the country, but it's the highest in the study states in the states that we've studied. There are a few states, and I'll talk about this a little bit later, there are a few states that don't participate in our programs, probably because the news is not good, and they're sick of seeing bad news all the time. There are many states in the country that we do not study because they don't have enough, high enough population or working population to give us the critical mass that we need for doing a statistical analysis. We do, in the states that we study, it involves around 70% of all claims in the whole country. So we are in the most populous states, and Pennsylvania certainly is in one of those states. On the right side, just to mention this, we look at the percentage of claims that are bumping up against the maximum allowable benefit. And Pennsylvania is typical around the median for that. Sometimes we'll see states that have very low benefits. Well, any of the high wage earners are going to be bumping up against that maximum. And what we look for is kind of a balance between what your benefit pays and how many people are maxing out. So you're paying a high benefit, but your max out rate is about average with other states. Excuse me. So we looked at the indemnity and the breakout of the indemnity, which is responsible for the majority of the higher overall claim cost in Pennsylvania. Looking at the medical side, we can see, as I said, we're talking about typical, lower, and higher. Offsetting components have overall made Pennsylvania really in the typical or average state for medical expenses. You've got lower prices and higher utilization offset each other to result in typical medical payments. The medical fee schedules in Pennsylvania have resulted in lower overall prices compared with other study states. The main driver of higher utilization was physical medicine services. You can see there at the bottom. In addition, proportionally more injured workers received at least one service in a hospital setting than in most study states. So, maybe I'll just save this slide for a second here. When we're looking at overall cost per claim, we also look at outcomes in various states. And what many stakeholders tell us is they're okay with higher costs as long as you're getting better outcomes than the average state. Lower cost states are probably okay with having lower outcomes. Really, the question is, are you getting what you're paying for? So here in Pennsylvania, as I mentioned, is one of the higher cost states. But when we look at the outcomes, and when we say outcomes, we're looking at the key outcomes measured are related to recovery of health and functioning, return to work, access to health care, which is measured as a percentage of workers who reported problems getting the desired services or the desired provider, and satisfaction with health care. Outcomes here, as you can see, for injured workers in Pennsylvania were similar to the median study state. We'll let you draw your own conclusions on that. So one of the factors in the higher indemnity costs are lump sum settlements. I think you call them compromise and release agreements in Pennsylvania. Well, you do a lot of compromising and releasing, I guess. So this is a look at the last 16 years or so, and these different colored lines are indicating the different duration, maturities of the claims, and you can see there's been some steady growth over the years in every category of duration. So it's something that is there. If it's working, I'm not going to make a judgment on whether this is good or bad. It's just a function of your law, and it seems like everybody must be liking it because you're doing a lot more of it than you have in year over year. There's growth in this area. We consider lump sum settlements as indemnity payments because when they come in through our data, some states report them strictly as indemnity, some report them as lump sums in a separate category, but it's all over the board. Even in some states, they report some as lump sum and others as not. So we just lump them all together in indemnity, and we consider that as part of the indemnity versus medical. The other factor about your lump sums in Pennsylvania is when the lump sums are paid, they were the highest of the study states of the amount being paid. So this figure here, $58,000, is what you are at 36 months of maturity in a claim. If we look at the claims 3 more years, at 72 months, then that number jumps up to $62,795. So there's no change in the relative position. Pennsylvania is still the highest in the study states for lump sums. All right, enough of that. Let's talk about opioids. I should have mentioned that WCRI studies so many different areas, all aspects of the benefit delivery system, but what we are asked to come and talk about most of the time is opioids. Opioids is in the news every day. When I checked into the hotel yesterday, there was a meeting going on in the hotel about opioids. If anyone saw the USA Today this morning, there's an insert in here from the CDC about opioid awareness. I encourage you to take a look. I thumbed through some of that already. Very good stuff. There's following the slides in your booklet, the slides that I brought and that I'm presenting on, it looks like Burke put in a whole document about CDC prescribing guidelines for opioids. If you go onto the CDC website, you can get this very concise 2-page outline of the guideline for prescribing opioids for chronic pain. A very interesting, quick reading, makes a lot of sense, very good common sense. But the point is, opioids are all around us, and they affect every family, every institution. They cut across gender, socioeconomic, and cultural strata. Everyone at least knows of someone who's been affected by opioids. It's not specifically a workers' comp problem, but we find in many states the only organizations that are trying to do something about it are workers' comp organizations. So we have been doing a lot of research, and we update our research every couple of years. It's a little frustrating, and some of the data that we're going to show you today was from a lot of it was from our 2017 research reports, which were looking at data that was finalized in the 2015 claim year from 2013 onset claims. So we're always looking at data that's a little old, but we're showing trends, and I think you'll find the trends are interesting. Just as an overview, the first couple of lines up there are reports that we're going to be referencing today. We looked at these claims from injuries from 2010 and then updated for injuries in 2013, each with 24-month maturities. So 2013 then becomes 2015, looking at the claims. We're looking at non-surgical claims with 7 days of lost time or more. The reason we look at non-surgical claims is because surgical claims almost always have some form of opioid dispensed either during the surgery or after the surgery, and so that would skew all of the results. So we're looking at non-surgical claims, and we're looking at large samples from 26 states. When we're talking about opioids, what are we actually talking about? So there's a few things on this chart I want to point out that will be the basis of some of the other charts that we go through. Namely, the second column is a federal schedule, and you see the federal government schedules strong medications and drugs 1 through 5. We don't see any Schedule 1s on this chart because Schedule 1 drugs are considered to have no medicinal purpose. Heroin is a Schedule 1 drug, by the way. Can anyone name a very popular other Schedule 1 drug? No? Marijuana, that's the one I was looking for. So we're going to be hearing a lot more about marijuana in the next talk. And maybe we'll hear something about whether there's going to be a change in the schedule. But right now, marijuana is considered a Schedule 1 drug. Now, the schedule usually goes, the lower the number, the more potent the drug. So 1s are going to be stronger than 2s, 2s stronger than 3s, and so forth. Marijuana, I don't know objectively really fits in that category, but we have experts here that can tell you more about that. What I would like to point out on this chart is hydrocodone used to be a Schedule 3, is now a Schedule 2. Hydrocodone combined with acetaminophen gives you drugs called Vicodin and Lortab are common examples. It's the most widely prescribed opioid for workers' compensation claims that we've seen. Followed by tramadol, which is a less potent drug, and then followed by oxycodone drugs. Now, oxycodone, Percocet and OxyContin are combinations of oxycodone and acetaminophen. OxyContin, a brand name, is a controlled release version of that drug. We're talking about opioids now, and we've been talking about them maybe for 20 years, but opioids have been around a long time. In fact, oxycodone was actually invented in 1917 in Germany, right around the same time that workers' compensation was invented in Germany in 1917. So they've kind of grown up together. And I'm not sure which one is in better shape right now. But it's interesting that we were talking about it now, and I was thinking back to what my mother used to give me, and there's other people of my vintage around here I can see today. When I was a baby and I was teething, my mother, the nurse, would give me an over-the-counter medication called paregoric. Does anyone remember paregoric? Do you know what paregoric is? It's tincture of opium. It was available over the counter until about 1970. Scary thought. But it was to control symptoms of diarrhea particularly, but mothers also used it to quiet babies down if they were teething. It did the trick. But it's just amazing how much things have changed in the 10 or 12 years since I was a baby. I will point out that we mentioned that as the schedules go down, or up in this case, they're more powerful, but hydrocodone was moved from a 3 to a 2, but oxycodone is about 50% more potent than hydrocodone. Okay. All right. So, this is an important slide, looking at all these different states. If you can find Pennsylvania, they're kind of left center there. This chart shows the percentage of claims that have pain medication that have an opioid. Now be careful. A lot of times people will see this and they'll quote these results incorrectly when they blog about what we're saying. We're not saying that at least 2 in 3 injured workers have opioids. We're saying at least 2 in 3 injured workers with pain medications have opioids. And there's a distinction there because not every injured worker gets pain medication. So in Pennsylvania, 67% of claimants get pain medications if they get opioids if they're getting pain medications. So of that, if you can see the 1 opioid prescription or 2 or more opioid prescriptions, in Pennsylvania, 27% got only 1 prescription, but 40% got 2 or more prescriptions. And we're looking at longer-term opioid use. We look at those that have had 2 or more prescriptions. And I think that's telling. In some states, you look at Louisiana, they're second to the right. They have the vast majority of their claimants get 2 or more, and many more prescriptions. So we can talk about how many prescriptions you get, but that doesn't give you the full picture of how many opioids or what degree of opioids you're getting. So we have a formula. And we're looking at MEA, or morphine equivalent amount. That's our terminology. It's not our personal terminology, but that's in the industry, that's the terminology. Morphine equivalent amount. And the formula is this. And we've got a sample claimant here. So these 2 prescriptions represent 1 claim. The number of prescriptions, so this person had 2. The quantity means the number of pills in the prescription. And so we have 40 and 60. The strength refers to the number of milligrams per pill. And then the morphine conversion factor is the relationship or the relative strength of that particular drug to morphine. And as I mentioned, hydrocodone has a 1-to-1 ratio. Vicodin is hydrocodone. 1-to-1 ratio with morphine. So their conversion factor is 1. And as I mentioned, that oxycodone is 50% more potent than hydrocodone, so that's a 1.5 conversion factor. So if you do the math, the first one's easy because the conversion factor is 1. So 1 times 5 milligrams times 40 pills gives you 200 MEA for that drug. So the total claim with these 2 prescriptions together is 1,100. So that's a sample. That's not Pennsylvania's sample, but that's just how we come up with the morphine equivalent amount, the MEA. This is a scary chart, and I won't go into too much detail except to show you that there's 3 states, Louisiana, Pennsylvania, and New York, that have very high MEAs per claim for a very small segment of the population. So in the 95th percentile of the population that workers' comp claims have very high MEA. I'm talking about 12,450 in Pennsylvania. So that one way of looking at it is 95% of the population of workers' comp claimants have a lot less than that. So only the top 5% have that. But it shows you that there is a problem with, if you think this is a problem, there is a problem in 3 states in particular with some claimants that have an extremely high dose or MEA per claim. We're going to talk about these major findings, and some I just mentioned a little bit. More than 2 out of 3 injured workers with pain medications, okay. I will show you that the frequency and the amount of opioids per claim decreased in most states over the study period. So we've updated research from 2010 to then to 2013, looking at those claims in 2015. We'll show that there's been a reduction in the use of opioids pretty much across the board. However, there are a few states that opioids still remain higher than other states. Also, I'm going to show you that opioids are frequently dispensed with other sedating drugs. We're going to talk about that. And then there are all kinds of guidelines and safeguards put in place, and we're going to talk about whether those guidelines are being followed. So this map is hard to look at. This is not one of our charts. This is put out by the CDC, showing just that opioids varied substantially across the country. Now, we refer to MEA, remember morphine equivalent amount? The CDC uses a different term called morphine milligram equivalents, or MME. I mean the same basic thing, okay? So don't be put off by that. The basic thing you can see from this chart, or this map, which is hard to see, is basically the darker shading is the higher amounts of opioids being prescribed. So this is by county. I don't know, can you find your own county up there in Pennsylvania or Maryland, or if anyone's from New York? You can see whether your county is one of the higher or lower. The next map I'll show you just shows that there's been changes. It says opioids prescribing decreased in several counties from 2010 to 2015. But you can also see that in the darker shading, it has actually increased in several counties. So overall, there's been a reduction in opioids, but not everywhere. So there's still problem areas, and there's some of that dark shading here in Pennsylvania. Okay, so we're looking at the MEA again. And you see New York, Pennsylvania, Louisiana. Louisiana is way off the charts there. We had to extend the chart special for them. You might ask, what's the median state? Median state is 1,400 MEA per life of the claim, 1,400. Pennsylvania there on the chart is at 2,621. Louisiana is at 3,539. I'll repeat that with those numbers. Pennsylvania, 2,621 MEA per claim. Louisiana, 3,539, where the median state is at 1,400. Now keep in mind, our research does not include some of the states that were on that CDC map that had a lot of dark shading, particularly Ohio, New Mexico, areas of Colorado, and Alabama. Okay? Some of those states, if we were to add them, would move Pennsylvania over to the left a little bit. So we continue to monitor opioid prescribing and have seen a reduction in most states from 3 years earlier. This shows the percent of the percent of claims with opioids. Okay? You find Pennsylvania there in the middle? That's about a 3% reduction in the percent of claims that have received opioids in the last study period. The next slide shows the actual amount of reduction in amount of opioids per claim. So here we go with the MEA has gone down in almost every state. Wisconsin has actually gone up, but Wisconsin, even with an increase, is still lower than most states. Pennsylvania there off to the right again. Pennsylvania, New York, Louisiana, all three states have seen a reduction, but still are high. New York saw, as you can see there, a significant reduction, but it's still quite high. I want to point out, is Kentucky on the map? Yes. So Kentucky also was one of those states that had a large reduction, still in the medium area. We're going to talk a little bit more in depth about what Kentucky has done to find that decline. So I think this slide is kind of logical. There's been a reduction in hydrocodone use, which was the most popular opioid prescribed for workers' comp claimants in our study. And along with the reduction in hydrocodone, we saw an increase in prescribing of non-opioid analgesics. Okay? So the doctors are giving people something, it's just not opioids. Some would call that progress. So what can be done on a state or federal level to combat the opioid problem if you see it as a problem? In recent years, there's been numerous efforts at the federal, state, and organizational levels to reduce opioid, what we call overuse. Among the most prominent federal efforts addressing opioid prescribing and dispensing are the upscheduling of hydrocodone and the Surgeon General's Turn the Tide program, along with the new CDC guidelines that I mentioned. The CDC guidelines came out in March 2016, limiting the amount of days that someone, the recommended amount of days that someone could receive supply for their opioids, and the requirements for getting additional prescriptions. The DEA in upscheduling hydrocodone did that because a lot of guidelines call for restrictions on Schedule 2 opioid, but don't call for restrictions on Schedule 3. So by making hydrocodone a Schedule 2, it would fall under some of those restrictions. But there are a lot of other programs that can be done on the state level, and we're going to talk about these PDMPs, which are prescription drug monitoring programs, drug formularies, limits on prescribing and dispensing of opioids, which you've done here in Pennsylvania, talk about treatment guidelines addressing opioids, and other policies. So this graph shows some of the states. It's hard to see at the top: Kentucky, New York, Maryland, Michigan, Tennessee, Massachusetts, and Texas. And what was done in those states, on the left side you see all of the different programs that were put in place to kind of safeguard or reduce opioid use, and they've had varying degrees of success. The double check marks for Kentucky and New York indicate that their PDMP is stronger than other states. I will mention that 49 states now use a PDMP. Does anyone know the state that doesn't have it? It's Missouri. They went through a long court process or a legislative process last year to try to fix that, but it remains the only state without a PDMP. And some PDMPs are stronger than others, and not all created equal. A few states have implemented workers' comp state-mandated drug formularies. We're going to talk about that. And then other states have put a limit on the number of opioids you could get. Last year, Massachusetts passed a law limiting first fills for opioids to a 7-day supply, with exceptions for chronic pain and cancer patients. and all states in the Northeast adopted limits on the first fills since then. We're going to look at some of the state examples of state policies that were implemented during the study period. I also mentioned that we're going to look at Kentucky. Kentucky, their PDMP is called Casper, and they implemented this. Kentucky had a large problem with opioids. You may have read about it in some of the books that are out on opioids. And they put in these mandatory use of PDMP. It's one thing to have a PDMP, but if there's no regulation saying you have to use it, you're not going to use it. They put in made theirs mandatory. House Bill 1 is what I'm referring to. They also regulated pain clinics, and they set up ownership and oversight requirements and criminal sanctions for violating the requirements. They've updated the PDMP, and they're taking it very seriously. So this is what happened. You see, to the left of the black line is pre-reform, and to the right of the black line is post-reform. They're using the PDMP. Okay. So that's pretty striking graph. Here we're looking at 4 states: Missouri, Indiana, Kentucky, and Illinois, in that order: Missouri, Indiana, Kentucky, and Illinois. And we're showing the difference between pre-reform and post-reform in Kentucky. Kentucky is the yellow line, relative to the other border states that they have. So something happened, and it coincides with their reform. So most logical people would presume that the change in the opioid use, the decrease in opioid use, was due probably to the implementation of House Bill 1. So that was the number of prescriptions. Now we're looking at the actual decline in morphine equivalent amount. The same 4 states in this order: Kentucky, Illinois, Indiana, Missouri. So all states, you can see, have had a reduction in opioid MEA, but Kentucky's was quite a bit more substantial. So we talked about PDMPs. You can see the results of a PDMP. We're going to take a look now and see how many states have done a PDMP. Well, as of today, 20 other states adopted similar mandates, at least for initial prescriptions. Although some of these are not effective yet, they'll become effective later in the year. The darker states require all prescribers to check the PDMP. The lighter states have conditions on when they have to check with the PDMP, like if the doctor believes a patient may be seeking opioids for non-medical reasons, or for treatment of a drug addiction, or for longer-term opioid use. So another tool in the toolbox, so we talked about PDMP, another tool in the toolbox of drug formularies. There's been a lot of activity surrounding workers' comp, state-mandated formularies. In workers' comp, a drug formulary is a list of drugs with each drug assigned a status requiring or not requiring pre-authorization to substantiate medical necessity prior to the prescribing. Some formularies have a Y and N terminology. Y for yes, N does not mean no, N just means non-formulary. That's what they say anyway. So here are the states that have implemented or passed legislation for drug formularies. Washington, North Dakota were the early adopters of workers' comp formularies. Texas and Ohio rolled out formularies in 2011. Texas model is based on ODG, or Official Disability Guidelines, which were adopted by several other jurisdictions. Arizona, Oklahoma, Tennessee also introduced formularies based on ODG. I think there's one that's Nevada, formularies based on ACOM. So there are different formularies out there. Some have used a Medicare basis. So there are different systems out there that states can try, and varying degrees of success. So here's a couple of examples. Ohio reported a 25% decrease in opioid prescriptions and a 74% decrease in muscle relaxant prescription. We're going to talk about muscle relaxants in a few minutes. But the point is, if you make someone go through a pre-authorization process to get an opioid, chances are you're going to reduce the amount of opioids being used. I'm going to move along here just to show that there are different things that you can do. Limits on prescribing and dispensing of opioids. Pennsylvania, as I mentioned, House Bill 1846, we want to talk about that a little bit. Some states ban physician dispensing altogether. It's still legal in Pennsylvania. It's illegal in many states, including Massachusetts. But Pennsylvania put in a reform that was based on, go to the Pennsylvania one. So the frequency and cost share of physician dispensed drugs decreased because of this, but what was it that they did? They capped reimbursement of physician dispensed drugs to 110% of the average wholesale price of the manufacturer's original NDC. Now, an NDC refers to the National Drug Code, which is the code you get when they first register a drug. And what drug companies were doing is repackaging drugs and giving them a whole new code, which gave them a whole new average wholesale price and let them charge whatever they wanted. This new reform says no, they can only use the original NDC and go for 110% of the average wholesale price. They also restricted physician dispensing of opioids and other drugs to limited time frames. And they said that doctors could no longer dispense over-the-counter drugs. They have to come through pharmacies. The effect of this law, you see, pre-reform, 35% of all prescriptions in Pennsylvania were dispensed at a doctor's office. After the reform, down to 11%. The spend, 51% in 2013 of the cost of all prescriptions in Pennsylvania was from these physician dispensing. After the reform, it went down to 4%. I think that's a pretty dramatic graph. So I wanted to point out that there was a decrease in the frequency of dispensing, decreases in the prices paid to physician dispensing, but also a significant increase in prescription payments for compound drugs over the same time period. So while the prices went down, the utilization went down of opioids in this time period, at the same time, there was a significant increase in prescription payments for compound drugs. The payments, though, were not being made by physician dispensers. They were being paid through new pharmacies that have popped up. So there's a lot of new pharmacies in Pennsylvania, and they're filling prescriptions for compound drugs, but only about 25% of those new pharmacies are responsible for the vast majority of these dispensing. I'm kind of running through that quickly to show you, but this graph you have in your materials. You can study it a little more closely, but it's interesting that the reform has had its desired effect, but then there's also one undesired effect, and that's the cropping up these new pharmacies that are filling prescriptions for compound medications. And finally, do I have a couple minutes more, Bert? Okay, thank you. I wanted to talk about treatment guidelines for addressing opioids. So you've got all of these things: PDMPs, drug formularies, limits on prescribing and dispensing of opioids, cutting down on physician dispensing. Treatment guidelines is another area that's out there, and they're talking about other types of treatment that can be offered for people that were receiving opioids or haven't received them yet, but can be prescribed other things. There are different guidelines out there. I mentioned ODG, ACOM, which is American College of Occupational Environmental Medicine. The CDC has chronic pain guidelines, and the Federation of State Medical Boards has their own guidelines, evidence-based guidelines. So a lot of states have adopted these guidelines, and they're talking about what other types of treatments are out there, whether it's acupuncture, physical therapy, doing drug testing, urine testing, to make sure there's compliance or not overuse. And I think the point is there are a lot of different tools in the toolbox that can be used to try to curb opioid use. You see them listed here. I think the telling slide is coming up next. All these things you've got at your disposal in many states, but are they actually being followed? Drug testing is done about 40% of the time when it's recommended. Psych-eval, psych treatment, almost never. Physical therapy, almost all the time. So I think insurance companies, employers are picking and choosing what they're going to do which of these guidelines do they want to follow, but they're not following all of them. And I think that people in the insurance industry especially shy away from using psych evaluation and psych treatment because they don't want to open another can of worms. But these are guidelines that have been shown to help reduce the effects or the use of opioid therapies over long term. I'm going to wrap this up. We talk about high-risk people. A small percentage of people, relatively small percentage of people, are using opioids on a long-term basis, but they're responsible for a lot of the expense and for a lot of the failure to return to work in your populations. So we're really studying heavily, closely looking at long-term opioid use. I would encourage you, if you have an interest in this area, to go onto our website and find the actual reports, because they go into so much more detail than I could do today. Wanted to take 1 minute and talk about this. So there's a high frequency of dispensing of other types of drugs, sedatives, with opioids, and the two in combination are in some cases lethal. And some states have a high percentage of this kind of concomitant use of different drugs. In Pennsylvania, that happens to be with sedatives like Ambien. In Massachusetts, it's with benzodiazepines, which are like Xanax, Valium, Klonopin, Librium, Ativan, those kind of drugs. Muscle relaxants, Flexeril, Soma. That's the cyclobenzaprine you might see. Right now, there's an effort to get away from the concomitant prescribing of both of these types of medications with opioids, because they're seeing the frequency of death for overdose is multiplied considerably when those drugs are used with opioids. So I want to just bring that to your attention. If you have claimants that are receiving both kinds of drugs, it's because the doctors gave them, prescribed them. It's not your claimant's fault, but it's something you should be aware of and be talking about how to better handle that claim. Okay, so no need to recap. We talked about all of these things. The slide is also in your booklet. I wanted to let you know that, whoops, I'm sorry, a little too far. My information is here. Our website is on there as well. I would encourage you to check us out. If you have further follow-up questions, I'll be here the rest of the program, and I'd be happy to answer any questions I can. And if I can't, I'll get answers when I get back to the office. Thank you, Gene.
No, just, I know Tim's organization is the only one that I would spend time in terms of looking at, in terms of learning what's going on nationally about workers' compensation. It's always, sometimes it provides comfort and sometimes it does not, but you'll learn if you go there. If you, a lot of material. If you have questions, we put out some very fancy pads of paper. Write some questions down, bring them up here, give them to me, and then we'll try to find some time to address those before we leave for lunch. So take a short break.